Okay, so now we are going to look at how, these compartments that we were talking about, the extracellular space and the intracellular space, or extracellular fluid and intracellular fluid, how they react to one another and how, fluid kind of passes through these compartments. To understand that, there are two main things, because it's dependent on these two. There are two main concepts that you should understand. One is called hydrostatic pressure, which I've written as HP, and the other one is osmotic pressure, which is OP. Hydrostatic pressure is nothing but fluid pressure. So automatically, the more fluid there is, the more pressure there will be. Okay? And for example, we did the glomerulus. It was dependent on that hydrostatic pressure. So when the afferent arteriole was nice and relaxed and a lot of blood flowed into the glomerulus, the efferent was constricted, so there was difficulty coming out. There was more fluid in the glomerulus, the hydrostatic pressure was more. Okay, so it's dependent on fluid pressure. Osmotic pressure is dependent on the presence of solutes. Solutes are like, for example, if you take salt and you dissolve it in water, the sodium and chloride are the solutes in it. Okay, the water is the solvent. So the more solutes there are, the greater the solutes, the greater the osmotic pressure. And if you remember from ANP1, if you remember greater the amount of solutes in anything, we call this solution hypertonic. You remember that? And what did hypertonic solutions do? They tended to draw water towards themselves, isn't it? So osmotic pressure would be in a closed area where, you cannot kind of change the volume. So the pressure increases and the capacity means it is to draw more water towards it. So if we look at a solution like this, which is, let's say, both solutions are 100 ml, this is all of water. So this would be hypotonic as compared to this one, which is also 100 ml, but of which, if I say 50 grams was sodium chloride and 50 ml was water, so you can see this would be hypertonic, okay? The other concept to understand is hydrostatic pressure tends to throw fluid out. As in the glomerulus, remember, the more the hydrostatic pressure, fluid was pushed out into the glomerular space. Another example I can give you is, let's say, you sit for a very long time, your veins get dilated because, there is no movement, the blood doesn't go back, venous return to the heart is impeded because no skeletal muscle activity. I gave you this example a long time ago, I think. If you sat maybe on a 5-6 hour flight without moving, right, your feet tend to swell a little bit because, again, the veins dilate in your feet. So in your feet, the veins become dilated because the blood is not going back up. So then the pressure inside the vein will increase, which is hydrostatic pressure. Fluid goes out, which is why it causes edema in the interstitial space, okay? So hydrostatic pressure tends to throw fluid out, and osmotic pressure tends to draw fluid in. So they do opposite things. And obviously, whichever one is more, that side kind of wins, which we will see in the next slide. Now let's look at these other things that I've drawn. So here, let's say you took this beaker, this same beaker, and you added fluid to it. So if you add fluid to it, what will happen? Your hydrostatic pressure would increase. Right? Your hydrostatic pressure would increase. To give you an example, let's say you drank a lot of water, right? So it'll be absorbed from your gastrointestinal tract, go into your blood vessels, so your blood volume will rise, which means your pressure will rise. Or if I gave someone an intravenous drip, and I forgot to turn it off after some time and then pushed a lot of fluid inside them, I'll push more fluid into their blood vessels, so hydrostatic pressure would increase. Look at what happens to osmotic pressure when you add fluid. So when you add fluid to this, what happens? You dilute the solutes, right? Because if this was 100 ml, this whole solution, of which 50 was sodium chloride, then we would say that sodium chloride is now 50% of this solution, isn't it? Now if I add fluid to it, so let's say if I add another 50 ml more, making this 150 ml. So now my sodium chloride is 50 over 150, which becomes 1/3, isn't it? So can you see that if you add fluid to anything, you may raise the hydrostatic pressure, but what will you do to the osmotic pressure? You will decrease the osmotic pressure, right? The pulling power will become decreased because the solutes will decrease. Let's see the other scenario. If we reduce fluid, so if we take fluid out, example is, let's say you've vomited, you've had diarrhea, you've had hemorrhage, so you've lost fluid. So when you lose fluid, what happens? Your solutes get concentrated. So it becomes even more hypertonic, right? So your osmotic pressure rises when fluid is lost, isn't it? Which is why, remember, the hypothalamus sense, those osmoreceptors sense when you get dehydrated. And when you lose fluids, what happens to your hydrostatic pressure? It would decrease, exactly. So your hydrostatic pressure would decrease, but your osmotic pressure would increase here. Okay? So you've understood this concept. So now let's move on to this slide, and I'm going to go back and forth between this one and the one next to it. So this is showing you the fluid compartments. So here we are looking at, this is showing you the cells. So this is the intracellular fluid compartment, intracellular. So the fluid inside the cells, which is the cytoplasm containing the containing water. And then this area is the interstitial fluid space. Remember, the interstitial fluid was the one which bathes the cells, right? This one was inside the blood vessels. Okay, so this was the plasma in the blood vessels. Both of these are outside the cell, so both of these would be part of what? Extracellular fluid. Excellent, right? They're outside the cell, so extracellular fluid. So extracellular fluid is made up of interstitial fluid, and of plasma. Now the ultimate purpose in this, if you notice in this, is that you want fluid actually needs to bathe these cells. You want important nutrients to go into the cells, and you want wastes and other products to come out of the cells, and that's how it will get into the blood vessel and it will pass out into, through the kidney, right? So look at it this way. This is showing you the arterial end of a capillary. This is showing you the venous end of a capillary. Remember, arteries, the pressure is very high. At the veins, venous end, the pressure becomes very low. So at the arterial end of the capillary, the hydrostatic pressure is, say, about 35 millimeters of mercury. And the osmotic pressure, because of the presence in the blood of your electrolytes, your albumin, globulin, all of those solutes, the osmotic pressure, they have said, is about 25 millimeters of mercury. Okay? So hydrostatic pressure tends to throw fluid out. Osmotic pressure tends to bring fluid back in. Now, which one wins in this case? Which is more? Hydrostatic. So because this is more than the osmotic, the net result is fluid will go out, right? So fluid will go out into the interstitial space. Then when we come into the venous end of the capillary, what happens is that the solutes, the osmotic pressure will remain the same, because the solutes are going to be the same. Whatever solutes were present here at the arterial end, the solutes are going to be the same at the venous end, right? But here, when you come to the venous end of the capillary, a lot of fluid has gone out. Flow has become sluggish, so there's less fluid present here. So you can see the hydrostatic pressure has dipped from 35 to 17. Can you see that? Right? So therefore now which one wins? The osmotic pressure. So it draws fluid in. So at the arterial end, fluid goes out. At the arterial end of the capillary, at the venous end, fluid goes back in. And that's how you kind of maintain your blood volume to a great extent. Now the same amount that went out is not the same amount that comes in, because some fluid is always left out, which is the one which is brought back by lymph. Okay? So you can see this hydrostatic pressure therefore pushes fluid out, osmotic pressure builds or pulls fluid in. The net movement depends on which one is higher. Now, over here, once this fluid has gone out into the interstitial space, you can understand then based now on the interstitial space up here, whatever the solute content is in the interstitial space, that will determine whether fluid will go into the cell or fluid will come out of the cell. Okay, right? So if we recap this, we can see that fluid movement between plasma in the blood vessels and the interstitial fluid is across the capillary walls, correct? On the osmotic movement between cellular across the plasma membrane of cells. So we go back here. So the fluid between and the cross the water is able to move freely between these two spaces, between the intracellular and cellular space. Which part has greater osmotic pressure, that will tend to draw the fluid into that space. But for certain large molecules of nutrients will go into cells because that's what nutrients come right. You don't want waste to go into the cells, you want them to come out. So that's specific of waste. The next thing, the fluid, that means the present in the interstitial space, that will determine the volume of intracellular fluid. Much solutes is present here. The extracellular fluid, that means here and here. The extracellular fluid solute concentration, which in other words determines the osmotic pressure, that will determine how much fluid is present inside the cells, right? If you think about it, suppose the solute concentration here in the interstitial fluid was to increase. What will happen? What will it do to the cells? Pull water out of the cells. If the solute concentration here decreases, what will it do to the cells? The cells will pull water into them, right? Isn't it? So the extracellular fluid solute concentration determines how much fluid there is going to be inside the intracellular space. It means, look at this again. So this is a kind of neat activity which tells you about blood vessels and how the pulling pressure. So here is, these are solutes, this is a bag, and then this shows you a mug. So here what we saw, we begin with two mesh bags and imagine each one is a blood vessel. Now what you're going to do is, these are measuring cups holding 4 sponges each. Each color represents a solute. So your job is to drag 6 measuring cups on the left to bag A and 3 measuring cups to bag B. So you can automatically see B has less solutes than A does. And now it says each is filled with particles similar to a person's blood, that means with solutes like albumin, sodium, glucose, and we can check the osmotic or pulling power. So you click on each bag and drag it into this bucket of water. And then now what we are going to do, measure the fluid in each of the bags, which is in the blood vessel. So let's take bag A. We'll do B. And you can see that A, which had more solutes, pulled in more fluid inside. So you can see that B has twice the pulling power, and that is because it has greater levels of these solutes like albumin, sodium and glucose. So the higher the osmolarity, the greater the pulling power, right? Okay. The greater the amount of particles, the stronger the pull of fluids in their direction. So if a client had a serum albumin of 1.9 grams per deciliter, would fluid be more likely to enter or stay in the vessel or leave it? Just take a guess. I mean, since you don't know whether 1.9 is normal, it's less or more. Just take a guess. Okay, you say stay in the vessel, okay. No, it's below normal. Okay, that was below. It's too low, so it will kind of be outside the vessel. Now, this one, glucose, you all know, right? What are the levels of glucose? If someone had a serum glucose of 566 milligrams per deciliter, would fluid be more likely to enter or stay in the vessel or leave it? Pardon? Yes. Because glucose, this is a very, very high glucose level. Okay, I think that. So now you can see this, how the solute concentration becomes so important. Look at fluid dehydrate, or you get severe hemorrhage. So what happens? You throw up, or you pass a lot of hemorrhage from go out, right? Fluid goes out, the solutes kind of get concentrated. So pressure inside them would increase. So what will happen? They will kind of pull fluid from the cells. When they pull fluid from the cells the opposite. If you urine quickly. But this is when you drink really fast. Your brain's not able to adjust. That's overhydration. So then your extracellular fluid, it dilates, right? Pressure is so push fluid into the cell, right? Because it cannot draw fluid. So it pushes in cells, kind of get really large, and they can even sort of swell and burst. Red blood cells. When you put red blood cells in hypotonic solutions, the red blood cell into it and dies, ruptures. Edema is a kind of situation. Here you're talking about, the solute concentration and so on. Edema is kind of a situation where you have, like I gave you an example of veins in your, and this side the hydrostatic has increased in such a case, so it remains in the interstitials. Edema is also seen in kidney disease when somebody loses solutes. So when they lose solutes, what happens? Their osmotic pressure tends to fall, goes why they puffy. Which of the following conditions will not increase osmotic? Drinking a lot of water. Look at this, all these three. Vomiting, you're losing fluid. Diarrhea, you're losing fluid. Similar hemorrhage, you're losing, severe hemorrhage, you're losing fluid. If you lose fluid, what happens? The solutes get concentrated. Osmotic pressure increases. Remember, osmotic pressure is dependent on solute content. So osmotic pressure increases. When you drink a lot of water, what you're doing, you're diluting it. So osmotic pressure decreases. Now let's look at water intake, output, and how we regulate the water and electrolytes. And this is really review of much of what you've done in the urinary, beginning of urinary physiology and even in the endocrine system. So when you look at your intake, you can see up in intake, 60% is what you drink in terms of, different beverages, water, and so on. 30% of it you get through metabolism of, 30% is through other food, that you eat, which may have fluids in them. And 10% of water comes from metabolism. When the cells metabolize you, they produce water. Now here we saw that in your intake, suppose you were sweating excessively and you didn't drink water, you were just working out for a long time in the sun and you just kept sweating. You lose a lot of fluid, could end up in dehydration. So the fluid loss is through the extracellular fluid space. So what does it do? It draws fluid from the intracellular fluid compartment, as we saw, from the cells. So when the cells shrink, what happens? It kind of activates the hypothalamic thirst center and you feel thirsty because they shrink as well. So that's in the intake. Let's look at output, what happens normally and how it will change. 60% of the water is lost through urine. Then we have, based on this, you can say the other about feces, you lose about 4% normally. Sweat is about 8%. Then through the skin, insensible perspiration, through lungs and so on, you have 28% which is lost. So this is about your normal daily output. There is some loss which has to happen from the kidneys because we all have to produce some volume of urine. So this is called an obligatory loss. We all have to pass feces, some through the feces and some obligatory loss through the lungs. But the rest of the water loss that remember we saw when you produce dilute urine or concentrated urine, that is dependent on the body's need and what happens to the body. So if you take a lot of water, a lot of beverages in, you automatically end up producing more urine. If you take less and you are sweating a lot because you are taking less and you are losing water, you automatically produce less. Remember concentrated urine, and here you would produce dilute urine. And you all know it is aldosterone and ADH which are kind of involved in this. Because if you have excessive intake of water, what happens? Your hypothalamic receptors, or osmoreceptors, are well hydrated, so they don't stimulate ADH production. Your collecting ducts become impermeable to water, you pass out water. If on the other hand you take less water in and you're dehydrated, the osmoreceptors also up here get dehydrated. They sense this. They cause ADH to be secreted, collecting ducts become permeable, water is reabsorbed and you produce less urine. If solutes are lost, then it's aldosterone which is involved, right? Electrolytes, for electrolyte balance, first of all it's aldosterone also which is involved, or ANP, atrial natriuretic peptide, depending on what needs to be excreted. And then also remember calcium, which was dependent on parathormone and calcitonin, parathormone being more important in the case of the kidney. And electrolyte balance also is to do with pH of blood, because hydrogen and bicarbonate ions are also electrolytes, right? So if your pH is very high, that means you have too few hydrogen ions, then what will happen? You will get rid of bicarbonate and you will reabsorb hydrogen ions so that you can bring your pH down. If on the other hand your pH is too low, that means it's acidic, you have too many hydrogen ions, you will get rid of this and you will reabsorb bicarbonate, which we'll see how acid-base balance is maintained, okay? So this is showing you regulation of water intake and output. So look at this, if there's a decreased plasma volume, say, you've lost fluid through any means, your blood pressure decreases, the kidneys sense that, they cause renin-angiotensin to be secreted, this which gets converted to angiotensin, this goes and acts on the hypothalamic center apart from also causing aldosterone. Now, apart from this, when you've lost fluid, your osmotic pressure increases, so extracellular fluid osmolarity rises, your mouth becomes extremely dry, so decreased saliva causes that dry mouth, plus the osmoreceptors also sense this, so they both act on the thirst center and it causes you to feel thirsty, so you drink water, it stretches your gastrointestinal tract, stomach and all of that. And that actually stops, it sort of negatively feeds back on the thirst center, because, you just drink a few sort of swigs of water and you feel kind of satisfied because the thirst center gets satisfied. That but let's say you continue to drink water, it's absorbed from the GI tract and everything comes back to normal. And here's the output. So again, the same situation. Let's say your osmolarity has increased because you have lost fluid. So then this stimulates the osmoreceptors. It goes to the posterior pituitary where ADH is stored. ADH is secreted, goes to the collecting ducts, makes them permeable to water. So water is reabsorbed and less urine, scanty means less, and concentrated urine is produced. At the same time, even the baroreceptors in the atria and blood vessels stimulate the pituitary to secrete ADH. And then when your volume rises, then, there's a negative feedback and then ADH is no longer secreted. Okay, so this is kind of really a review of everything that you've done so far. Okay, let's look at this. If you ever seen a dehydrated person, you would have noticed that they, the eyes look very sunken. The skin turgor means the elasticity of the skin. Like if you pull on the skin, it's not elastic. The mouth is extremely dry. Why do you think this happens? ICC stands for intracellular compartment, ECC for extracellular. Well, the person looks like this because the cells have shrunk, right? So fluid has moved from the intracellular compartment to the extracellular compartment. The cells have shrunk. Remember this slide that we saw. This slide. See this? When you lose a lot of fluid, cells have to lose it. So the cells look shrunken. That's why your face and everything kind of looks that way, okay? So when you lose water, remember, it's the cells which shrink because fluid cell, fluid moves from the compartment to the intracellular compartment or make your cells swollen, right? That's not what happens. Let's look at acid-base balance. pH is a measure of the free hydrogen ions in blood. From 0 to 7, it's acidic, and we say it's a low pH. From 7 to 14, 7 is the neutral pH, so literally 7.1 really. 7 to 14 is alkaline or basic, and we often say that's high pH. And you must understand, when it's a low pH, it actually means there are more hydrogen ions. When it's a high pH, it means there are less hydrogen ions, because pH is how many hydrogen ions there are in the blood, okay? So low acidic pH means more hydrogen ions. Alkaline is a high pH, but there are fewer hydrogen ions. So that's an inverse relationship between the number and the amount of hydrogen ions. Now our blood pH is between 7.35 to 7.45. So we say this pH it's a physiological pH, this one, because this is the optimal pH at which all body functions occur. Okay, so this is the optimal temp. So we say blood pH is alkaline. It's a little bit more than just 7. So that is because that's the optimal level at which all body functions occur. Now, in our body, we have certain systems we always try to keep the blood at this pH, 7.35 to 7. We don't want it to shift. So which means that if hydrogen ions are being produced in excess, we need something to mop up those hydrogen ions. If they are being produced, less is being produced, we need something to release the hydrogen ions so that we can keep it at this pH. So that is done by buffer systems, which, in other words, they resist the change in pH. And they do this by either giving up hydrogen ions or mopping up hydrogen ions. Some of these buffer systems you've actually seen. So these are a few of the buffer systems which we have in our body. There's this chemical acid-base buffer, which is called the bicarbonate buffer system. You all saw when we were doing the respiratory system. Remember, carbon dioxide with water formed carbonic acid, then formed bicarbonate and hydrogen ions, right? So we have this bicarbonate buffer system. So it's the carbonic acid and what is called sodium hydrogen carbonate. Then we have protein buffers. Again, in the respiratory system, you saw hemoglobin, which is a protein buffer. We also have plasma proteins, which act as buffers. So when hydrogen ions are given up, the hemoglobin mops it up, or even the plasma proteins do. So once it's attached to something, the hydrogen ions don't have any effect on pH. It's only when they are free that the pH rises or falls, depending on how much there is. And then we have also got phosphate buffers, which are seen in the kidney, and you'll see how these again help to mop up hydrogen ions. Now we have terms called acidosis and alkalosis. Acidosis obviously is a condition where the pH has fallen and it's acidic, so that means there's more hydrogen ions. Alkalosis would be a condition where the pH has risen, it's high, so there are fewer hydrogen ions. And there are two kinds of acidosis and alkalosis. One which is to do with the metabolism in your body. So if someone is exercising a lot, what will happen? They tend to produce more carbon dioxide. Carbon dioxide interacts with water. If you remember from this, carbon dioxide interacts with water. We always have water inside our cells. This produces the carbonic acid, which gives rise to hydrogen plus bicarbonate. So you see, if you produce more of this, can you see more of hydrogen ions will be produced, right? So if the body is not able to kind of compensate, if the hydrogen increasing metabolic acid and the less and is less than this, then you get something known as metabolic alkalosis. The way the body responds to anything which is going inside your cells is for the respiratory system to compensate. So we'll see what happens. Again, you can use it in daily life. The respiratory metabolic acidosis. However, suppose the respiratory system not works, and let's say a person is not breathing properly. So they breathe 15 breaths, breathing even slower. So what happens? The carbon dioxide will build up in their blood. So they will end up with something called red because of respiratory problems. Got that? On the other hand, imagine someone who's hyperventilating. So they keep on hyperventilating. There's some proper ventilation. In effect, your alcohol respiratory origin. So since it's a problem with the lungs, obviously compensate. The kidneys compensate in such situations. Okay? So this is quite simple to understand, that if the problem is something to do with acidosis, so metabolic problems, the respiratory system also can compensate in this situation. So first, how hemoglobin acts. I'm using one buffer system, how hemoglobin acts as a buffer. So you look here. So this was outside the red cell and this was in the red cell. So look at this, carbon dioxide plus water forms carbonic acid, which immediately breaks up into bicarbonate and hydrogen ions. We don't want these hydrogen ions to remain free. So here we have hemoglobin, which is present because it was attached to oxygen. It kind of dissociated from oxygen. Oxygen goes into the cell, so hemoglobin is now free. When it's free, it immediately mops up these hydrogen ions. So you can see that it buffers, so it prevents the increase of hydrogen ions in the blood. Okay. Here also in the plasma, look at this, carbon dioxide and water forming carbonic acid, breaking up into bicarbonate and hydrogen ions. These guys get bound to plasma proteins. So can you see how proteins here also act as buffers? So they prevent it from lying loose and decreasing the pH. Okay. So that's how hemoglobin acts as a buffer. All of the others act in similar manner. Here, let's look at the kidneys. So in the kidneys here you can see, So if I point up here, so look at the same situation up here. So just concentrate on this area. So carbon dioxide and water form carbonic acid, which breaks up into bicarbonate and hydrogen ions. This bicarbonate, let's say, goes into the bloodstream. The hydrogen ions are going into the filtrate. Where can you see the bicarbonate which has been filtered attaches to the hydrogen ions, forms carbonic acid which breaks up into water and carbon dioxide, and that goes back into the cell. So here the bicarbonate has buffered it. Do you notice? Okay. Here again, here's a thing which showing you how phosphate acts as a buffer. Same way, water and carbon dioxide form carbonic acid which forms hydrogen and bicarbonate. The hydrogen goes out into the lumen where this hydrogen phosphate is waiting for it. It attaches to it and forms dihydrogen phosphate, and the bicarbonate goes here. So you can see how phosphate also is acting as a buffer, right? Let's look at this. What acidosis is a condition when, so let's answer this one. Acidosis is a condition when the pH falls, when the hydrogen ion concentration increases. And when I say hydrogen ion here, I'm automatically talking about free hydrogen ion concentrations. Remember, this falls, this is fallen, the number has fallen, but in acidosis, the hydrogen ion concentration has increased. So it's both. Okay? It's both. So let's see how respiratory system regulates this acid-base balance, and it's really common sense. So think of this. We saw this reoxide plus which breaks up carbonate. We don't hydrogen is sort of bound first, and so your pH doesn't change. But in a case excessive metabolism, say like you're exercising and doing something and there's excessive production whenever more CO2, the equation will go this way. So your hydrogen ions could keep on getting increased and maybe they're not getting buffered properly. So the hydrogen ions, so your pH falls, so you end up with acidosis. So to compensate and if I don't know if you remember from respiratory system, remember carbon dioxide was a very powerful respiratory stimulant. So this in it respiratory ventilate. When you happen, you keep flushing out the dioxide. So if you're flushed out as soon as it is formed, you automatically help to prevent building up of hydrogen ions, right? And think of it yourself, long run, right? In the beginning, after seeing a little body is CO2, you need to get rid of that and you begin to hyperventilate to get rid, right? Think of the other situation when there is reduced metabolism or excessive loss of acid. Reduced metabolism, let's say for example, let's say some people are buried in an avalanche sometimes, you have that, right? And they have vomit, lose hydrochloric acid. So hydrogen ion concentration is down, which means your pH number has gone up, so it's become alkali. To do so there's less CO2 in the body, so your respiratory system is depressed and you hypoventilate. You don't breathe as carbon dioxide. You will then you bring the normal, right? Have you followed? So it's common sense. Okay. Look at renal regulation. So the renal system also does it the same way. This compensates when the respiratory system is at fault. So let's say, like I said, someone is hyperventilating due to extreme stress or severe pain, and they keep on sort of hyperventilating. They flush carbon dioxide from the body. When they flush that, fewer hydrogen ions, so your pH increases and it becomes alkaline. So you have alkalosis in this situation. So in this situation, you'll have alkalosis. So the problem is with the respiratory system, so it is what is doing hyperventilation, leading to this alkalosis. So now what do you want to do? You want to make sure that there's less hydrogen ions. So you have to do something so that you conserve hydrogen ions so that you can bring the pH back to normal. So what the kidneys do is they increase bicarbonate secretion inside the lumen, or they don't reclaim, they just let it pass, and they absorb hydrogen ions. When they reabsorb those hydrogen ions, they can push that into the bloodstream, so your hydrogen ion level will increase and your pH will come back to normal, right? If on the other hand, in the respiratory system, if the person hypoventilates, so there's increased carbon dioxide and hydrogen ion retention in the blood, so there is a low pH, which means in this case there is an acidosis, and this would be of respiratory origin. So there is acidosis. So what the kidneys can do is they cause now hydrogen ion to be secreted into the lumen and passed out in the urine, and they retain bicarbonate. So therefore here they again bring the pH back to normal. So here you may want to write, in this case, they increase hydrogen ion secretion in urine and they reabsorb more hydrogen ions and push this hydrogen ions into the bloodstream so that you can make the pH, bring down the pH to a lower level and, achieve homeostasis. Got that? Think about it. If you have more hydrogen ions, you want to get rid of it. So the kidneys will throw it out in the urine. If you have less hydrogen ions, the kidneys don't want to throw hydrogen out, right? They want to reabsorb it. Instead, what will they throw? Bicarbonate out in the urine. Okay, so it's really, like I said, it's really common sense. Okay, so let's look at this question. Suppose the metabolism increases such as while exercising. What is the best way for the respiratory system to maintain homeostasis? Yes, increase respiratory rate, because if your metabolism increases, remember, more CO2. More CO2 means more hydrogen ions. So if you hyperventilate, you remove the CO2, so you prevent the hydrogen ions from increasing. Suppose the person hypoventilates, what would be the best way for the kidneys to maintain pH balance? So think, when you hypoventilate, what are you retaining? And what do you want to get rid of? Oops. Okay. The correct answer, they secrete hydrogen ions into the filtrate. See, here I'm telling you what the person is doing. So if a person is hypoventilating, right, what will happen? They're breathing less frequently than they should normally do. So there's some respiratory problem. So when they breathe less frequently, what is going to build up in their blood? CO2, isn't it? CO2 then will interact with water, will form this carbonic acid, which will give rise to hydrogen ions and bicarbonate, right? So here I'm telling you that the person is hypoventilating. That means they're having a respiratory problem, which is why they're hypoventilating. So when CO2 builds up in your blood, so what will happen? When it builds up in your blood, you're going to produce more hydrogen ions. You want to get rid of these hydrogen ions. The way you can get rid of the hydrogen ions is if the kidney pushes them out into the filtrate, right? Into the urine. This should really be urine. And therefore, what will happen? You will actually reabsorb bicarbonate but push this out. Have you understood here? Okay. So do not confuse between what the respiratory system will do and what the kidney will do. Here I'm not telling you what the respiratory system, I'm not giving you a compensatory mechanism of the respiratory system. What I'm telling you is that there's some problem with the respiratory system. That's why the person is hypoventilating. And now I'm telling you, so this will lead to respiratory acidosis. So now what will the kidney do? Okay, have you followed that? So kind of understand this situation. Okay, any questions?